I'll be talking about VA-ECLS and LV unloading. These are my disclosure. I have no conflict of interest at all. So let me just introduce myself a bit. My name is Enrico, and I'm a certified clinical perfusionist working in the Department of Cardiac Surgery at the Mater Dei Hospital, that is a private institution of my city, Bari. That is a beautiful sunny place that you can easily find looking in the middle of the hill of the boot. I'm also a medical student here at the University of Bari and a Ph.D. fellow at the Heart and Vascular Center of the Maastricht University Medical Center in the Netherlands. I would like to start this talk with a brief recap of VA-ECMO indications. The classic indication is cardiogenic shock, defined by decreased cardiac output and contractility resulting in hypoperfusion. This can happen from either an acute event, such as a large myocardial infarction, or worsening of a chronic process, ischemic or not. Though randomized data does not exist, nor suggests that the use of VA-ECMO in acute MI complicated by cardiogenic shock improves in-hospital survival and reduces 30-day mortality when used in conjunction with the revascularization. Cardiogenic shock can also occur as a result of a non-ischemic process. The most common are fulminant myocarditis and septic cardiomyopathy. Patients with fulminant myocarditis bridged to recovery with VA-ECMO may have outcomes similar to myocarditis patients without shock. Data for VA-ECMO in mixed cardiogenic and septic shock is less consistent, though a role may exist in patients for whom benefits outweigh the risk of bleeding and thrombosis. Finally, VA-ECMO can also be used in post-cardiotomy shock when patients are unable to immediately be weaned from cardiopulmonary bypass. More recently, patients with pulmonary hypertension and PE with right heart failure have also emerged as candidates for VA-ECMO as a bridge to a more definitive treatment, such as particularly in the compensation, of course. Extracorporeal CPR is yet another use of VA-ECMO to assist in restoring circulation during cardiac arrest. Data show improved in-hospital survival and survival free of major neurologic impairment up to 2 years when VA-ECMO is used in conjunction with CPR in selected patients. In addition to shock, VA-ECMO has an expanding role in class 4 stage D heart failure. Similar to utilization in post-cardiotomy shock, VA-ECMO has been used with success in patient post-heart transplantation with the primary graft dysfunction and myocardial rejection with hemodynamic instability. In these cases, early initiation of ECMO has been shown to have a more favorable patient outcomes. In fact, patients supported early by VA-ECMO who survived past the initial event can have comparable survival rates to those without primary graft dysfunction. Finally, VA-ECMO is also being used as a bridge to LVAD implantation or transplantation with terminal heart failure. It can also be used as a bridge to decision in a decompensating patient in whom prognosis may be uncertain. So coming back to the topic, allow me to say that LV unloading during VA-ECMO is a controversial issue. I will start giving you this simple idea. Whenever you have a damaged muscle, an injured muscle, how do you react? You put the muscle at rest. This is exactly the concept applied in the context of veno-venous ECMO. And the literature is very consistent about the idea of lung at rest. So the question at this point is, are we really putting the heart at rest during VA-ECMO? Are we protecting the heart, or are we adding some additional harm? We will address this point. These are pressure volume loops that clearly demonstrate what I'm saying. Here you can see a normal situation, but in case of LV dysfunction, of course, the heart works much less, and there is an of the intrachamber pressure. This is what happens when we start the ECMO. It has been clearly shown that when you start VA-ECMO in the scenario of a damaged heart, the flow going against the opening of the aortic valve increases the intracardiac pressure while decreasing the stroke volume. Ergo, in one way, we are not helping, but increasing the heart's work. This is what happens if we combine VA-ECMO with LV unloading. As you can see, the combination of VA support plus LV venting makes the PV loop looking way better by means of the reduction of the intrachamber pressure. So, as I show you with the PV loop, usually, not all the times, but often, the scenario during VA-ECMO is the one of left ventricular overload. Can you see the pointer? Okay. So the scenario is the one of left ventricular overload. Consequently, you have left ventricular dilatation. You have increased LA pressure, you can have pulmonary congestion, and of course, in the worst scenario, you can have pulmonary edema. In the acute setting, as you all know, the LV dilatation increases also the wall stress and the oxygen demand. So we can have subendocardial ischemia to support worsening an already compromised myocardium. But another issue is that if we are impeding LV unloading, we can induce aortic valve closure, which can be protracted. And if this happens, we can have blood stasis in the ventricle, in the atrium, and in the lungs. So at the end, in the worst scenario, we can have ischemia, we can have pulmonary edema, and we can have thrombosis. But what is the frequency? What is the incidence of the situation? And after all, is LV unloading a major determinant for the outcome? This is a paper that I want to show you because it gives an idea of how variable is the perception of the phenomenon. This is from Regenes. Their experience, they have more than 600 patients, and the rates of LV unloading need, that means that they did it, was less than 2%. The reason why is the idea of less is more. In fact, they accepted a mean arterial pressure below 50 millimeters of mercury, even with no pulsatility for more than 24 hours, which is something that, for instance, in my end, I do not accept for more than 2-3 hours. They also accepted low flow rates. They use a restrictive fluid management and high PEEP in order to decrease pulmonary edema. This is another paper published in a thyroid journal in 2017 from the Columbia Group. In their experience, 7% of patients required immediate LV decompression, and 22% of the patients had subclinical signs of LV distension. However, not enough to warrant immediate decompression. So as you can see, we are talking about different numbers, from 2%, less than 2%, to 22%. This is another paper from a German group published in Perfusion. Their rates of LV unloading was 4%, but most important, you can see that these 11 patients on 281 have something in common. They are half post-cardiotomy patients and half post-cardiac arrest. So these are the type of patients that experience thrombus formation during VA ECMO. And what you can see is that the 30-day mortality of this patient was much worse. This can sound very trivial, but it is just to highlight again once more that when you face that vicious circle of stasis, thrombosis, edema, and ischemia, it's very difficult to get rid of this condition, and the patient outcome is going to be very poor. This is a paper from my group in Maastricht, in which they were testing an intra-aortic balloon pump, EABP, as first-line strategy in case of protracted aortic valve closure. Their incidence of LV unloading by means of EABP was 6% in 10 years' time. So again, 2% in the Regensburg experience, 7% from the Columbia Group, 4% again from Germany, and here we have 6%. Moreover, EABP was effective in 80% of cases. If this converts to a favorable outcome is controversial. In fact, 8 out of 10 of these patients actually died. This is another very interesting paper about the use of VA ECMO and Impella. In 66 patients, they look at the need of LV unloading in the 30 patients treated with VA ECMO alone as compared to the 36 who had ECMO plus Impella. And in this experience, almost 60%, 58% of these patients in the VA ECMO group required surgical venting. Again, from 2%, 4%, 6%, we go up to 60%. Just to underline that most likely is the center approach, is the attitude that makes the issue common or not. Moreover, in this study, we can appreciate differences in short and long-term survival between the groups. So some evidence is on its way, but that maybe LV unloading may be important in patient outcomes. This is another famous paper from 2 centers, one in Milan, one in Hamburg. Again, Impella plus VA ECMO or ECMO alone. In a propensity score analysis, they showed that the combination of the devices was effective in terms of in-hospital survival and weaning. On the other hand, the rates of hemolysis and acute kidney failure were higher in the group treated more aggressively. Again, this can sound trivial, but is very useful to underline this point. So the question is, LV unloading, when? This is a paper published in Perfusion that gives you the idea of which parameters must be taken into account when evaluating of LV decompression. As you can see, the arterial line pulsatility, which is very important, but also some other factors such as echocardiographic signs like the smoke-like effect, other clinical signs like the wedge pressure, signs of congestion, etc. However, the take-home message is that a strict monitoring is mandatory in patients treated with VA ECMO, and that looking for signs of LV compression is so important because it can avoid the patient to get into that vicious circle of stasis, thrombosis, ischemia, and pulmonary edema that for sure is going to jeopardize the outcome. So, of course, we have several strategies. I will go through this in a while. Just focus on the fact that according on the system you use, there are different effects, and this should be taken into account when you want to implement ECMO with the LV unloading. Of course, an impella is different from EABP, is different from septostomy. The approach must be patient-suited. But first of all, you have always to keep in mind that you can start with easy, simple things such as drugs, the so-called pharmacological venting. You can start with inotropes and even with vasodilators. Of course, you need to find an equilibrium. You need to have a strict monitoring and because pushing inotropes, pushing vasodilators can be also detrimental in this kind of situation. So watch out, but this is also a strategy, is feasible. There are also some ventilatory strategies such as higher PEEP, prolonged inspiration time, and perhaps lower tidal volume that can be helpful in this situation by means of a more effective drainage. But which are the other strategies? And how much are they used? Of course, this is a paper from Maastricht published in 2017, and you can see that the rates of the different strategies of LV unloading are the following. So the 1/3 of transaortic, basically impella, 1/3 of EABP, and 1/3 again of left atrial, so transeptal or septostomy. You can see that there are very low rates of pulmonary artery venting and direct surgical venting, which in my opinion are very effective, but this is just my cup of tea. So this table shows the pros and the cons of each strategy. But what I don't want you to go through this. I mean, you can just download the paper. You can find the reference right here. What I want to say is that you can have a direct or an indirect unloading. It can be a less or a more complex approach. It can also be less or more effective, and of course, it can be less or more expensive. Putting a EABP is completely different from putting an impella. Completely. So this is a paper from the group of Nicolas Préchaud and Alain Combe from Paris. They demonstrates how the simple use of the ABP, that is a very familiar tool, was effective in reducing the occurrence of pulmonary edema in patients treated with VA ECLS. This just confirms the results of the previous study from Maastricht that I showed you, in which again EABP was effective in 80% of cases in the improvement of the aortic valve opening. So again, EABP, for example, is a simple, reliable, well-known, not expensive tool that we can use in this situation. And it is available not just in high-profile institutions. However, aside of these strategies, I have to say that LV unloading is not just a piece of cake. In fact, you can have to deal with many complications such as bleeding, perforation, thrombosis, hemolysis, and acute kidney failure, persistent aortic valve closure, but also air embolism, and last but not the least, infections. All these complications can really threaten the results of our ECMO support. And even more, I have to say that there is still a big room for research, given that we don't even know the incidence of these complications. So coming to our conclusion, LV unloading is very important in the context of VA ECMO, but still we don't know if it's maybe underutilized. We don't have peremptory knowledge about the when and how. And finally, we don't know if it's game-changing for our patients. However, the real take-home message for you all is that a protective heart management is mandatory as much as we do with the protective lung management. And when I say protective heart management, I certainly mean LV unloading, which can be achieved in many ways, as I show you. But more important is that signs of LV distension must be strictly looked at twice a day, or I would say twice a day. So at the end of the day, I can provocatively say that LV unloading is the real heart assistance, or maybe the assistance of the assistance. So thank you. I'll be open for questions later on, and feel free to email me if you have any doubts.